So good morning. Yes. Thank you. Yes. Thank you. Yes. Round of applause to everyone who made it on time for the Friday morning. So thanks everyone, and welcome to day 2 of the summit. I think most of you know my name is Mark Gilbert. I work at the Ontario HIV Treatment Network, and it gives me a great deal of pleasure to sort of introduce and set up today's sort of dedicated health literacy stream here at the summit. Just to put that in context, so as I mentioned yesterday, we were able to get some funding from CIHR to support people coming to the summit, and then we have a dedicated stream of presentations and breakout sessions today related to health literacy that are all taking place within this auditorium. We want the dialogue to happen sort of within this forum, so please engage and give us your questions and please comment on what you think. But I'm very excited to sort of kick off today with our special guest, Irv Rootman. We had some tastes of and discussions of health literacy yesterday and some ideas about what that might mean. And the point of this session is really to establish a basic foundation in all of us in terms of an understanding of health literacy as a principle, as a concept, to understand sort of the lay of the land and to really understand kind of what's been going on in the field of health literacy so that we can then think about how we apply that to our work in the field of HIV prevention and gay men's health. So allow me to introduce Irv. Irv is an adjunct professor in the School of Public Health and Social Policy at the University of Victoria and a visiting professor in gerontology at Simon Fraser University. He's been a researcher, research manager, program manager, professor and consultant in the field of health promotion for more than 30 years. Currently, he's the co-chair of the Capacity Building Committee for the Public Health Association of British Columbia, as well as the chair of the Steering Committee for the BC Health Literacy Network. He was a member of the U.S. Institute of Medicine Expert Committee on Health Literacy and co-chair of the Canadian Expert Panel on Health Literacy. He's conducted research on health literacy and published numerous papers and articles on the topic since 2003. Since I've been telling people about this workshop, everyone always says to me, so is Irv Rootman coming? And so I think we're very lucky to have Irv Rootman here today. Please join me in welcoming him this morning.
Well, thanks for that introduction, Mark. It turns out I actually didn't have very far to come because I actually teach in this building. So even though I've done all those things, I actually live here within about half a mile of this place. So it wasn't hard for me to get here. But I have to say I am delighted. I was particularly delighted yesterday to be able to come to the summit part of this 3-day affair on health literacy because I was really impressed with the quality of the presentations and the discussions that went on yesterday. And I was absolutely thrilled that you had decided to focus on health literacy for your summit and workshop this year. Personally, I've been very committed to the concept for at least the last 10 years. I did research, as you heard from my CV, I did research on health literacy while out here at University of Victoria, and I've been retired now for about 7 years and am still very committed to health literacy, no longer as a researcher, but more as an advocate for the concept. The reason I really like this concept has to do with my professional background in health promotion. As you heard, I've been in health promotion for about 30 years. And I first became acquainted with the concept of health literacy in 1998. And when I heard about it, I realized that it was an absolutely critical concept for health promotion because it fits extremely well with the core concept of health promotion, which is empowerment. What better way to empower people than to help them be health literate? So that caught me on the concept of health literacy, and as you can see, I've been bitten, and I'm still bitten by the concept. And as long as I live, I think this is probably going to be what I'm working on, is getting health literacy on the policy agenda here in Canada. we're very good about writing words down on paper, but we seem to have a lot more difficulty getting things put into policy, depending on the ideology of the governments that are in power. So that's kind of introductory comments. So what I'm going to cover in the, I guess about 30 minutes that I have left is these questions about health literacy. Where did it come from? What is it? Why is it important? Why is it important for gay men's health? And what's the state of health literacy research? And finally, what are some implications for research on gay men's health literacy? Because my understanding is that this grant that Mark has is intended to produce a proposal for some research on health literacy. So I think we all have an opportunity here to shape what that research might look like. And I think it's really important that he's working with the community that this research is going to serve directly. So where did the concept come from? I think the first mention that was in the literature was in 1974, and it was a paper based on a conference on health education in the States. And it was put forward by a guy by the name of Simmons, who was a health educator and was particularly concerned about the health literacy levels of school children. And what he argued in the paper was that health literacy was a key outcome of health education, and that it really needs to be measured in order to be able to see whether or not young people who were going through health education programs actually were learning anything that would be helpful to them in their future lives. And so he made that statement, and then everybody forgot about it for about 20 years. And until it was picked up by a organization of state health counselors in the States, and they introduced a program to measure health literacy across the United States using it as an outcome of health education, and that program's still in place. So health education was one of the areas that was important in the development of this concept of health literacy, and I guess we have to give them the credit for being the first out of the stocks. But in the early 1990s, there was another group of people who were started to get interest in health literacy, and these were primary care physicians who were very concerned because probably about 40 or 50%, if not more of the times, their patients didn't understand what the hell they were talking about, and moreover didn't know what to do with what they were saying. And so they thought, well, you know, maybe there's a problem here. Maybe people aren't understanding because they don't have the skills. So they set about doing research to determine whether having literacy skills actually had an impact on health outcomes. And so they produced a whole pile of research on that topic, and in fact found that indeed it did have an impact on various kinds of health outcomes, which I'll talk about later. But what that did was it got it on the agenda of the American Medical Association, and they set up a committee to look at health literacy, and then the Institute of Medicine set up a committee to look at health literacy, but mostly from a healthcare perspective. They were really interested in healthcare. They weren't all that interested in prevention or health promotion or health education, maybe a little bit on health education, more patient education than health education. So that's the second kind of source of thinking about health literacy. The third is the area of health communication, which personally I see as part of health promotion, but it does exist as a independent field in and of itself, particularly in the United States. There's a very strong contingent of people who do and are trained to do health communication. As far as I know, there's no official training program for health education in Canada, health communication in Canada, which kind of annoys me a lot, but there you go. So in 1995, a fellow by the name of Scott Ritson, who was the director of a health communication program at 2 universities in Boston, decided that he wanted to put together a journal of health communication research. And he did that, and it ultimately became an international journal. And that journal featured a lot of articles on the topic of health literacy, and in fact, over the past few years has had large supplements on that topic. And Scott Ratson himself was very responsible for developing the concept in the United States. So health communication was the third strand. And then finally, us folks in health promotion caught up, and it started with Alona Kickbush, who at that time was the director of the health promotion group at the European office of the World Health Organization. I think the group only consisted of about 2 people, so she wasn't directing too many people, but she was very influential in the field by putting forward ideas that people should consider in the field of health promotion. And she mentioned it in an article, I think in 1997, which was 1 year before I actually came in contact with the concept. And she also worked with a fellow by the name of Nutbeam, Don Nutbeam. He actually wrote a book called Health Promotion Theory in a Nutshell. Guess where he got the title from. But anyways, Don Nutbeam also started writing about health literacy, and one of the things that he said was that people working in health promotion should look at health literacy as an outcome that we can be held responsible for. And that kind of resonated with me as well, because I did a lot of work during the 90s in terms of evaluation and health promotion. And we were always looking for outcomes that were measurable and so on. So that was another thing that got me hooked on health promotion. So anyways, these are some of the strands that developed the field of health promotion. They all went off in kind of their own directions for a while, but increasingly they're starting to come together and develop some kind of consensus around, what the hell are we all talking about? And so I want to move on to, got to do this one, right? Move on to talking about what is health literacy. And Paul had a good start yesterday, but I'm going to bore you with a little more detail and try and deconstruct it a little more than Paul did. I hope you don't mind, Paul. So anyways, this is sort of my view of it. I think these are key elements of health literacy, which you find in most of the existing definitions of health literacy. It's all about information, particularly health information. It contains different actors, which break down into people who provide information and people who receive information. It requires capacities and skills, and it is related to context. And so I want to just sort of unpack that a little bit for you and let you know what that contains. So in terms of information, health literacy draws on various kinds of types of information, prose information, document information, numerical information. This really comes from the general literacy field, which actually is fairly closely related to health literacy. In fact, I would argue that health literacy is founded on general literacy. And Laurie Donnell, who's sitting in the front row, is going to talk a lot more about numerical literacy later. Yes?
The slide's not changing.
Oh, it isn't changing? Why is it doing that to me?
Should we use the arrow keys?
What? Did it change? No? Can't trust technology,
Do you
eh?
want to just use the arrow keys to just go back
Okay,
and
I'll
forth?
give you, that's fine.
Is that Could you?
Oh, wait, go back.
Then you can use this one.
Okay, yes. Wait a second, I ended up going further than I wanted to. Okay. Do you think that's going to work now? I'm not a technology buff, so when anything goes wrong technologically, forget it. Okay, so we've got these four elements. So in terms of information, there are different types, and I talked about the first type, three types, and different content. It covers a number of different fields and topics. It uses different media, as written, oral, electronic, and so on, and different levels from simple to complex. There are different actors involved in the area. It kind of divides between people who provide, people in institutions that provide information and people that actually receive the information. And most of the focus up to this point in time has been on the recipients rather than on the people who are providing the information, the people and the systems that are providing the information. Although it's starting to shift now more to a focus on all three of these constituencies, which I think is a really good development. So in terms of capacities, most of the definitions contain one or more of these types of capacities: accessing information, understanding it, appraising it, communicating it, and applying it. Some of the definitions don't use some of these terms, and there are some definitions that use all of these terms. And as you can see, they have various elements in there. Another way of looking at skills, which Paul mentioned yesterday, was in terms of levels, and Don Nutbeam suggested that there were three levels: functional health literacy, which has to do with reading, writing, and numeracy; interactive, which has to do with advanced cognitive, social, and literacy skills; and then critical health literacy, which are advanced analytical, advocacy, and social skills. And then finally, health context, which in my view is one of the most important elements to understand in relation to health literacy, because health literacy is totally a contextual matter. And I'll be getting into that a little bit more. So there are a number of, when we're talking about the health context, which is a context in which health literacy develops or doesn't develop, there are a number of other contexts that make up that health context. It includes various kinds of settings. You can receive health information at home, on the street, in the market, in the political arena, and so on. The social group that you belong to, or cultural group to you, may determine the kind of information that you receive and how you interpret it. The individual's own features may determine, and we heard a lot about this yesterday, may determine how the information is received and processed. And the providers and the systems are really important to consider. In fact, I added this one today because I reread Mark's proposal, and he talks about the provider and system factors, and I think they're really important to unpack. And I think probably by the time today and tomorrow is over, we'll have unpacked quite a lot of that stuff. Okay, now some definitions. It looks like I'm going slower than I thought I would go, so if anybody wants me to hurry, go like that. So I just wanted to show you a few definitions of health literacy, and these are definitions that are fairly commonly used. The first one that probably is more used than any other definition, particularly in the United States, which has quite a large health literacy industry at this point in time because of the support of the medical people. They defined it in this in the expert committee report as the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. So these are kind of some of these words you'll see in other definitions, others you won't. The only definition that I've seen that uses process is this U.S. definition. But you'll also notice that this definition doesn't say anything about context. And that wasn't because the committee, which I was part of, didn't recognize the importance of context, particularly the health context. So we had a debate on what definition to use, and in the end we used that definition because it had been developed by Scott Ratson and Ruth Parker 2 years earlier in the setting goals for the nation exercise in the U.S., which actually set a goal on health literacy. And it might be the only, I'm not sure, but it might be the only country in the world that actually has a specific goal or objective on health literacy. And maybe Paul can speak more to that, but that's my understanding. Anyway, so this is a framework, and it makes it very clear that health literacy doesn't really stand on its own. It has to do with the context in which the information is provided and received, and it has to do with the individuals and how they can process the information demands that are put on them. It also makes very clear that it's not isolated from literacy per se, although there are some people in the field who argue that you don't actually have to be literate in order to be health literate, but I find that a little hard to take. However, maybe I'm just dumb. So these are two definitions that I had my hand in. This was, the first one was a definition that our research group came up with when we were starting to do research in the area of health literacy. And we identified kind of four key components of health literacy: accessing, understanding, appraising, and communicating. And I didn't highlight the understand because that was also in the Institute of Medicine definition, and which we used kind of as a basis for creating this. So we kind of took apart the notion of process and defined it in terms of appraising and communicating. The other things that we added to the definition were context, because I always felt that context was so important it actually should be part of the definition. And we also added the notion of life course, because it was very apparent to us when we looked at the literature that the information demands on individuals vary over the life course, and individuals' capacities vary over the life course. And ironically, when you get to be my age, like 73 last week, your capacity is at its lowest point and the demands are at the highest point. So anyways, that was the first definition we came up with. And then I ended up co-chairing the Canadian expert panel on health literacy. And being a good Democrat, I conceded to my fellow panelists in terms of the wording. They felt this definition, ours was too complicated and it needed to be stripped down a little bit. So they came up with a kind of stripped down and maybe a more user-friendly definition. And instead of assessing, they used the word evaluate. And they also put in the notion of improving health, which I think is a good addition. And then they talked about a variety of settings instead of talking about context. They equated settings with context. And as you see from the previous slide, context is a lot richer concept than settings is. Settings is part of context, but there are many other elements that go into context. I'm just looking, where's my thing here? Okay. Now we go to Calgary, which I was born in. One of the other people here was born in Calgary too. Anybody else from Calgary? Oh, good. We'll have to talk afterwards. I haven't been there for about 40 years, but anyways, we may have some commonalities here. So there was, this is a weird thing, but there was an Institute on Health Literacy held in Calgary, I think it was in 2008, sponsored by the Quebec Centre for Literacy, which seems to have a national mandate. And that group was really, really concerned about the issue of context. And so it wanted to make the point that health literacy was more than just the individual receiving information and processing it. In other words, if they don't process it right, then they're responsible for it. It has to do with the other elements in the context that have some responsibility as well. They also added the notion of using information. Now, we didn't use that, we didn't put that in our definition because we were trying to do research. And I think people need to keep in mind that a definition needs to fit the purpose, and our purpose was to do research. So we took a definition that kind of excluded the use of the information so that we could look at the relationship between health literacy and use of information to see, whether it makes any difference to raise people's health literacy levels in terms of how they apply information. So but this group in Calgary, and again I got ruled here, decided to add use into the definition. And others have done that as well, and I'm going to show you one other definition along those lines. This brings me to the European definitions, and the first one there is the one by Ilona Kickbush and one of her colleagues, who define health literacy entirely in terms of being able to make decisions. In other words, the use of the information. And I would see that more as an outcome than as a core element of health literacy. But we could have a good debate on that, and some people take a different view. And the other European definition, which was based on a kind of a review of a variety of definitions, essentially takes the same kind of perspective, but not quite as heavily. And they added a few other things in there too, like knowledge and motivation, which I would see again as being kind of outside of health literacy, as kind of a determinant of health literacy. But what do I know? Okay, next. Did I get a next slide? Okay, so just a quick summary. Does anybody here think it's not a complex concept? Okay, well, at least I've convinced you of that. That's good. There is no complete agreement on the definition, and I think we're going to be fighting the definitional wars for a long time yet. But there is a growing agreement on the key elements. I think people are increasingly recognizing that health literacy is not just a property of the individual, it's a property of the individual in interaction with health information providers and systems. So, some people have taken the view that let's not get too hung up over definitions. We're never going to get one that we all agree on. My view is that we shouldn't just throw out with the bathwater all the existing definitions, but I think what makes more sense is to kind of build on one or more of the existing definitions to come up with a definition that fits the context. And I'm going to suggest one later on for the context of gay men's health literacy. Okay, so how much time do you want me to go? Another 20 minutes? Well, that'll take me right to, okay, whatever. All right, so I'm very easygoing this morning. It's because I only had 3 hours sleep, but anyhow, so why is health literacy important in general? And these are the key reasons why health literacy is important in general for society, for healthcare system, and for individuals. So those are 6 reasons, or 7 depending on how you count them. So I'm just going to quickly go through them. There's no question that large numbers of individuals are affected. The last survey that was done nationally in Canada was in 2003, and it was part of the International Literacy Survey. What was done was the investigators took all of the items having to do with health and created a measure of health literacy out of that. And based on that, it turned out that almost 60% of adult Canadians don't have the minimum level of health literacy for that particular survey, which was level 3, which is a lot of people. And in terms of seniors, it was around 88%. So there's a margin of error on this thing, but whatever the margin of error is, it means there's a lot of people in Canada that don't have the health literacy skills that they need in order to be able to access, understand, evaluate, and communicate health information. Poor health outcomes. As I mentioned, in the States, they've done all these studies on outcomes, and they found it's related to longer hospitalizations, higher diabetes rates, lower self-reported health, and higher mortality, which surprised me a little bit. But there have been a couple of studies along those lines suggesting that people who have low health literacy are more likely to die sooner than people who have higher health literacy, controlling for a lot of the factors that you would think might have an influence, such as income and education. Health compromising behaviors. These are just some of the health compromising behaviors that are associated with low health literacy. Sort of inappropriate medication use, less use of preventive services, and less care seeking, less expression of health concerns, and difficulties using the health care system, all of which would rebound on to people's health and their need for care. Does anybody here think there isn't an increase in chronic diseases in Canada? Okay, well, I don't have to convince you of that then, but you can read the number there in terms of diabetes. It looks like it's going to be up to 2.4 million Canadians in 2016. That's a lot of people. And one of the approaches that is being used in relation to these chronic diseases is patient self-management. In other words, patients are asked and sometimes trained to manage their chronic disease, whatever the chronic disease might be. But it turns out that people with low health literacy either aren't able to do it or don't want to do it. So there's an issue there in terms of trying to raise the levels of health literacy enough so that people can do chronic disease self-management, or meet them halfway, which is the other strategy. Personally, I don't think we're ever going to get everybody at the upper level of health literacy, maybe not in this century anyways, but maybe in the next century. So I think we need to try. It's a goal for us, but I don't think we're ever going to reach that in our time. So given that, then the system and the providers need to respond to that deficit in health literacy. And I might also add that even people who are at the upper end of the health literacy scale might not be health literate in every single situation. And it could be that, when they go in to see their doctor and they're about to get a diagnosis of cancer or some other horrible disease, that they might not be quite as health literate as they would be otherwise. So, it's very situational and contextual. Cost, there hasn't been a definitive study of cost in Canada, or probably not in any other country, but wherever they try to estimate costs, they come up with a big number. So we took the results of a European study on cost and projected it to the Canadian situation, and we estimated an extra $8 billion a year on healthcare as a result of low health literacy. Who knows? I'm not going to sell my house on the basis of that. But anyways, it's still a concern. Complex health information, again, is there anybody here who doesn't think that the health information that we're getting over the internet is complex? or the information that we get from our doctors sometimes is very complex and maybe getting more complex, and all of the information is very confusing and makes it very difficult for people to understand and evaluate what they're reading or hearing orally. And equity is another big issue related to health literacy. There are certain population groups have lower levels of health literacy, and there's a list up here that popped out of the national survey. And, in the most cases, it's not their fault. They didn't have access to the opportunities that they would need to be health literate, or they didn't have access to the corrections that might be made to help them when they need to be health literate. And two guys in the States have argued that health literacy is an ethical imperative for healthcare, and under-examined mechanism for health inequalities. They suggest that the problem of limited health literacy should primarily be understood as an issue of health inequality and justice. And just a juicy quote to summarize it from the Office of the Director of the National Institutes for Health. Health literacy pervades health issues at all levels: prevention, diagnosis, intervention, and cure for both chronic and acute diseases. Health literacy also pervades social issues, disparities, cultural differences, language differences, and access issues. There's also an economic strain, both on the individual and on the system, in terms of lost human capital, lost time, and money. So if that isn't a strong argument for trying to do something to address the issue of health literacy, then I'm a monkey's uncle. Well, maybe I am. I don't know. Okay, so now I've been talking at the deficit side of the equation, which pains me because from a health promotion point of view, I like to talk more about people's assets than people's deficits. So I've turned some of these things around and stated them in positive terms. So health literate people have fewer ER visits, have more health knowledge and skills, communicate better with healthcare providers, manage chronic diseases better, and participate more in health promoting activities. So it's not only is low health literacy a bad thing, but high health literacy is a good thing. And why is it important for gay men? And this is, my guess at it, because, and it's kind of decontextualized. I think that probably all of you can come up with better reasons than I have why it should be important. And I think we heard a number of them yesterday. But just sort of drawing from the existing literature, I'd say that it's important because it will improve navigation of the healthcare system. It improves the ability to share information with providers. It improves self-management, decision-making and advocacy, ability to reduce health risks and health outcomes and longevity. And that's directly for a gay person or a gay man. But also you have to look at the impact of going through providers and the information system. So if providers are health literate themselves, and their health literacy means a little bit something different than the health literacy of a patient or a member of the public, then they will be able to provide more accessible and appropriate information and better care and support. So this helps gay men as well. And the information systems will also support the efforts of providers and lead to the development of policies to encourage health literacy improvement. Okay, now I'm going to talk a bit about the strengths of health literacy research, and I don't know, Paul might dispute some of these with me. I don't know, and probably has a few others that he could add, but kind of taking, this is my own sense of what we've accomplished since we got into this area 15 or so years ago. There has been a significant increase in researchers and research in the last decade. I think this is particularly true in the United States, but it's also happening here in Canada as well as in the UK and Scotland. I think there's a whole bunch there in Scotland, besides you, Paul, right? You're not the only one. And so I think that's an accomplishment. We've got people who are really interested in health literacy. And I think there's also been a lot of conceptual and theoretical development. I've shown you some of the conceptual development where we seem to be converging a bit. It's taken us a while to do it, but we're getting there. And there's also some interesting theoretical developments, development of conceptual frameworks and theoretical models for understanding health literacy. But I'm not going to show you any of those because that'll make your eyes go crossed. And new measures have been developed. We've done quite a bit in Canada to develop some new measures of health literacy. Our group, for example, developed a measure of health literacy for high school students. There's a couple people in Toronto that developed an e-health literacy measure. That's a measure of health literacy over the internet. And there's somebody also in Toronto that developed an oral health literacy scale. And at the national level, there's a man by the name of Scott Murray who's developing a self-report measure of health literacy that can be used over the World Wide Web. So we've done quite a bit there, and other countries have as well. The European Union has been very active in that area and have developed new surveys to get at health literacy. There have been many studies on the impact, which I've talked to you about, and I think that is an accomplishment we ought to acknowledge. On the other hand, it's still a young field, and we have some deficits, including the research having been focused on individuals. Most of it is focused on individuals, and not all that much on the providers and the systems, which, as I pointed out, is as important as the individuals who are receiving the information, and on certain groups. And I think gay men is a good example, although from what I saw yesterday, you guys are going to move out to the forefront. There's also a dearth of formal intervention evaluation and participatory research. I'm particularly keen, being from a health promotion background, particularly keen on participatory research, which has been shown to be promising in this field, but there's not enough done of it, and I think this community would be a great community for doing participatory research in this area. There's a lack of standardization in measurement tools and agreement on what needs to be measured, for example, the key outcomes, and a lack of emphasis on research related to equity in the social context and few applications to practice and policy. So we still have a ways to go, but I'm hoping that people in groups like this are going to push the envelope and deal with some of these issues over the next decade or so. There are gaps in the literature on health literacy and sexual health, and these are the ones that Mark identified in his proposal, so you can hold him responsible in case any of them are wrong. But he convinced the CIHR that these were gaps, so I guess it's a pretty good list. Now, about a year and a half ago, there was a meeting held here in Vancouver. It was at, where the hell was it now? Do you remember? That was at UBC. Okay, so rival institution, but anyways, no, well, actually, you're from UBC. You were from UBC too. But it was an international workshop on health literacy. Focused on health literacy and chronic disease management. And they had people from a number of countries come together and look at health literacy in relation to chronic disease management. And they made, it was an excellent workshop. Laurie Donnell was there, and I'm sure she would agree with me. But they made a number of recommendations for health literacy research. These are three of them: emphasize the generation of policy and practice relevant data, widen the lens to capture and evaluate the contribution of health information and care providers and systems, undertake research to develop tools to measure and understand context-specific variation, including over the life course, isolate elements of health literacy in a consistent manner, broaden means for conducting research. They, like RCTs, I got them to put participatory research in there as well. And then they suggested over the short term, this is what the focus should be, at least with respect to chronic disease management, looking at the patient experience, the role of new technologies, communication proficiency, and cultural competence of providers, quality of information resources, cost implications, and chronic disease management. And some of these areas, I think you've already started to pick up on from what I could see yesterday. So you're already implementing their recommendation without actually having ever seen it, which is okay. All right, what if I, oh yes, now I'm almost finished. You'll be happy to hear. So implications for research on gay men's health literacy. This is kind of a short list that I drew from what I've done. Modify a definition that fits the context of gay men's health. Carefully describe the context of gay men's health literacy. Focus on measurement in relation to individual gay men and providers and systems that deliver health information to gay men. Emphasize development of policy and practice relevant research for gay men. Undertake research and develop tools and measures to understand context-specific variation over the life course of gay men. Use multiple methods and approaches, including participatory research. See, I was able to take out the RCTs, but put participatory research. But I'm not saying that RCTs aren't valuable, but I think those guys kind of overshot the mark there a little bit. So this is a suggestion for a modified definition, and basically what I did was I took the two definitions that we had come up with, the one that our research team came up with, and then the one that our expert panel came up with, and I squished them together because actually there were nice elements of both of them. So I added gay men here, and I added the health context of gay men, and I added improve health in a variety of settings. So I've covered the waterfront in that definition. And I also want to say that about a year or so ago, there was a European project looking at health literacy in older adults. And they did a Delphi process to try to determine what kind of definition they should use for health literacy. And they put our first definition in as one of the options. And I was just blown away when I found out that most of the respondents actually preferred our definition over the definition that they had come up with. So that made me feel pretty good and made me think that maybe we were on the right track. Now, I'm also putting up a modified definition, which Paul cited yesterday, which I think is an interesting one as well. It comes more out of a European tradition. I think it's built on that last European definition that I put up there, but it's got some other interesting elements to it. So, here's one definition, modified definition to deal with gay health literacy, and another to deal with sexual health literacy. But I want to say that, go back to what I said before about the importance of fitting the definition to the purpose of the definition. So, if you're communicating with the general public, and this is actually something that came out of one of the sessions that I attended yesterday. You have to be very careful about the language that you're using. You have to be careful about how long it is and so on. So a definition that you might use for the general public could have elements of a definition that you use for research, but they don't have to be the same definitions. Now, this is the last slide, and I'm doing a commercial for the next speaker. This is a book that just came out this year called Health Literacy in Canada, and Laurie Donnell is one of the authors and editors of that book. And one of the quotes that I pulled out for it, because I didn't have a chance to say too much about intersectoral strategies, but they suggest that we believe that improving health literacy for all Canadians will require multidisciplinary, multicultural, and intersectoral strategies. And I think that's a true statement. And if you read the book, you'll realize why they came up with that statement. So I think that's it.